Hello, and welcome to the Pulse of Manatee on Manatee Educational Television. I'm your host, Dr. Srinivas Iyengar, cardiologist at Braden Cardiology Center. October, as many know, is Breast Cancer Awareness Month. While 1 in 30 women will be affected by breast cancer during their lifetime, 1 out of every 4 women will be affected by heart disease, according to the American Heart Association. Today's episode is dedicated to women and heart health. We have an all-female panel joining me today, including Donna Disbrow from the American Heart Association, who is also Vice President of the Cardiovascular Services at Blake Medical Center, family physician Dr. Karen Brader from the Bradenton East Integrative Medicine, and from the University of South Florida, we have Associate Professor of Medicine, Dr. Maya Guglin. Thank you all for being here, and let's begin. So, ladies, I'd like to welcome you first of all to the show, and the main thing is today we want to talk about women's heart health. So, Karen, we're going to start here. Being a family practitioner here in the community, what do you see normally when a patient comes in who's a female from a heart perspective? What gives you the red flags? What do you like to look for when a patient comes in of, say, a family history of heart disease?
The first thing I look at is really family history. Part of the evaluation of a new person coming in is figuring out what their antecedent events have been. Are they eating a heart-healthy kind of diet? Do they get some exercise? Do they take care of themselves? Most women don't really identify themselves as being at risk of heart disease unless their mom, their cousin, their sister, somebody else in their family in large numbers have had heart disease. So I think they're very often unaware. So we sit down and just talk about how their life has been going, how they're feeling, what they do to take care of themselves, and then I try and convince them to have some testing done to just look at basic risk factors, mostly checking cholesterol and blood chemistries and looking for metabolic syndrome.
Absolutely,
and sets people up.
And that is very important to mention that the dietary habits of many of these patients, really people don't realize that type 2 diabetes, is pretty rampant right now in our society. And Maya, in your estimation, when you see patients come to the office, now normally you're seeing patients a little bit more further down the line that have been diagnosed with heart disease. Now, what is your perspective on seeing female patients versus male patients in your office?
Oh, well, everybody has a heart. Women have heart. Male patients have heart. Disease is pretty much the same, but they present a little bit differently. First, there is difference in the age of presentation. Fortunately for women, they are protected from most ominous heart conditions like heart attacks by their hormones. Estrogen protect them till about 50, 55 years of age. After this, they kind of catch up with men in this respect, unfortunately. But before that, it's pretty unusual for women to present with a serious cardiac condition, or should I better say, serious ischemic heart condition. But I would totally agree with Karen that if it is in their genes, it's very difficult to overcome even with most vigorous exercises or stringent diet. If their mom, sister, or even somebody along their paternal line had the disease early in life, they are at high risk.
Well, that makes sense because you can choose your friends, but you can't choose your relatives. Now, Donna, you had a significant amount of experience working with these types of patients.
Yes.
What are the age ranges? What's the youngest you've seen actually in a female population come into?
Oh, we have seen women well into their early 30s, all the way up to advanced age, of course. I think the thing that I would like to say about that is that women largely think of this as a man's disease. And as we all know, it is not a man's disease. As you said, 1 in 4 women will die from cardiovascular disease.
And that's something that I think everybody at home should understand. Breast cancer awareness is given a significant amount of publicity, and for the right reasons, don't get me wrong, but I think that heart disease in women is kind of downplayed. Do you not agree?
Oh, absolutely. I would, my message that I would love to have all women understand is that while we do have controllable and certain risk factors that we can't control, as heredity, there are many risk factors that we can control, and we need to know what our own personal risk factors are, what our cholesterol is, what our blood pressure is, and then all of those things that we can do to control those, modify those risk factors.
Well, this is one risk factor that I find very difficult in my office to deal with, and that's smoking. In the sense that patients, man or woman, both have those major issue, and smoking, as we all know, is really negative on the outcomes of heart disease. Karen, how do you deal with patients who smoke in the office, especially females? What's your plan of action usually?
Number one is to identify it. I'm amazed at how many women, how many patients altogether have said, "You're the first doctor who ever told me to stop smoking." How could that be? I guess we get discouraged just like anyone else
Exactly,
does.
and I think that's right. The discouragement and
Right.
the fact of not bringing it up and having patients being angry at the confrontation, but sometimes you have to confront the patient.
Right. So first to say, this really is a problem, and I'm sure you know it's a problem, but let's figure out are you ready? Are you interested? Where are you on that continuum? And then if they say, forget it, no interest, I'm never gonna stop smoking, I love it, it's my only vice, leave me alone, say, okay, well, we'll talk about it again next year, because you may change your mind, and it's important that you don't smoke because it raises your risk of heart attack and stroke and, never mind lung cancer and so many other things. The person who's interested, then there are lots of different things that we can do to help people, and I'll spend 10, 15 minutes actually sometimes talking about all the different strategies that people can use. And there are many resources in the community where people can go for some assistance in actually stopping smoking.
Now, Maya, what do you suggest? What have you seen work?
I knew one great cardiologist who would just say to this patient, if you continue smoking, go find another doctor. I'm not going to take care of you anymore. But this man was so great that it worked in many cases. People would hate to give him up as their personal cardiologist, so they would quit smoking.
A tough love. I mean, sometimes you have to do that with the patients. I mean, you have to lay down the law. Unfortunately, in this day and age, I'm not sure many people are willing to do that to lose the potential patient. And I mean, and the fact is, there are all alternatives to quitting smoking. Donna, have you seen anything particularly work?
And what I'd like to just add to that is that educating the community. First of all, if you don't smoke, please do not ever start. The Center for Disease Control tells us that smoking is the single greatest threat to human health. And that reaches well beyond, as you were saying, beyond heart disease, but the cancers and many other, respiratory ailments. So, yes, smoking is a challenge. Smoking cessation, we offer classes, and of course there are medications and many things, support groups that can assist anyone that does struggle with the addiction of smoking.
Now, another thing that I find a number of times with my patients is the fact that women are caretakers. They take care of the family, take care of the children, sometimes take care of the parents, as well as obviously the husbands who often need the care as well. The thing is, they don't look at their own health that seriously, and they neglect their own health. How do you convince a patient, a female that comes in who does have these situations where she has young kids, or grown kids for that matter, and a husband and parents that she might be taking care of, that she needs to take time for herself? How do you convince that type of person to say, listen, you got to put yourself in front of the family at certain points? Is there any particular way that you've worked with that, as opposed to saying, listen, you can't neglect your family, but you have to take care of yourself first?
I use the family. I use what motivates them as the hook. If I know that this person is a caretaking woman, then I say, you want to be around in order to take care of your children, to be there for the people that you love, your parents. And you can't do that if you're not taking some care of yourself. You need to de-stress. Let your adrenal glands just calm down. Take time for a massage. Just do something every day that feeds your heart and your soul so that you can go forward and do the things that mean so much to you, that define who you are.
And it's important you say that, Karen, because the constant theme that I always bring up is a positive mind leads to a positive body. If you don't take time for yourself and clear the stress out, potentially that can lead to deleterious effects down the road. You can actually harbor that stress in your body by taking care of your kids and your husband, and that leads to, as we all know, stress does lead to worsening cardiovascular events.
Yes.
I also encourage them to bring their family members
Good
to
point.
the office. Because, I don't know what they're going to say to their husbands and their children. They may downplay what you tell them in the office. But if we have the discussion all together, and if they hear from me or from other cardiologists that this is serious, they may be taking it more seriously.
Absolutely. And Donna, I know that you see patients outside of where we see them normally, maybe in the rehab center, maybe obviously in follow-ups.
Yes.
What do the patients tell you when they say they're stressed at home? How do you deal with that normally?
Well, very much like what you said, to take personal interest in yourself. Part of a cardiac rehabilitation program is looking at what each one of those risk factors that individual has. And then we do a very specific plan of care and to build a program for that person to modify those risk factors, and if it's stress in their life, whatever that might be, managing blood pressure, et cetera, but it's very personalized. And I would like to just add, when you talk about the young women and not having that awareness of their own personal risks, we often think of it as a man's disease, an advanced stage, and yet I have a passion as well as a profession in the field of cardiovascular disease. My passion stems from a personal story from my cousin. She was 42 years old, and she had 3 children. And she was a tall, lean, professional, very bright, very active. And her oldest daughter found her dead from a heart attack in her kitchen floor at the age of 42. And the fallout from that was a life of that family growing up without their mother. And so the emphasis that I would like to say there is knowing what your own risk factors are, what your numbers are, and that's one of the things the American Heart Association's message is, to get that word out to women to know what your personal situation is so that you don't have that facing you someday.
That's a great point. Those are excellent, and that's a sad anecdote, but it's a true anecdote.
Absolutely.
It's something that people should understand,
Yes.
that when these events happen, the family's left without the primary care person.
Correct.
And something they should be aware of. Maya?
It is so important because, we're getting so good in predicting and prognosing and forecasting things for like 1,000 people, right? It's 1,000 women. But we don't know what is going to happen with this specific, with this
Correct.
individual, right? And that's where individual risk factors come into play. Their heritage, their bad habits, good habits, exercise habits, everything.
Now, Maya, tell me something about when your center, specifically at USF now, you're dealing with more of the end-stage patients that are coming in with heart failure, shall we say, the ones that are actually already diagnosed. Women with heart failure, in your estimation, do they seem to be responding to therapy better or equal to the males that you're seeing?
It's a very broad category, women or in general patients with heart failure, and different treatments benefit different groups or subsets in a different way. But for example, women in particular are very responsive to a number of very effective treatments of heart failure or cardiomyopathies if they present early in the course of the disease. So I would encourage everybody, and since we're having this conversation, women in particular, to pay attention how their breathing is. If the same amount of exercise or same kind of activity that was easily tolerated yesterday suddenly brings up breathlessness or fatigue, it could be a red flag for them that something serious is going on, and it's probably time to visit your family doctor or to visit us, yes. And to find out, is it something behind it or not.
Absolutely, and I do agree that the family physician plus the specialist has to be a cohesive group.
Absolutely.
You can't just have, because the specialist will, unfortunately, I fall into that trap a lot of times where we look at specifically one organ, where there's the systemic approach that needs to be done as well. And so I think you need to have more than one person involved when you're diagnosing or treating these patients. Now, Karen, medication-wise, how do you feel when you see these patients in the office? Is there compliance issues usually with their heart disease medications, like their beta blockers, their aspirin, their Plavix potentially if they have stents?
No one really likes to take their medication all the time. And many people are trying to get off of it for just because they want to be off of medication. But when you found a medication combination that works well to keep someone's symptoms controlled, and you know that the studies show that outcomes are much better when people take these medications in terms of preventing a second event, then it's incumbent upon us as doctors to let them know that and help them find ways to take their medications consistently. But side effects can be a problem, and if you work with trying to find an alternative medication that reaches the same goal that is tolerable, that's good. But Plavix and aspirin, those are difficult because people bruise and they don't like all those unsightly bruises on their arms.
I was just going to say that to women out there, that means the Plavix is working, so continue. But you're right, because women will come to the office constantly complaining, like, look at my legs, look at my arms, I can't even walk outside without a full sweater and pants. Men say, yeah, I bruise, but you know what, that's part of the process. So it's clearly a cosmetic issue.
And they think they feel ill. I look terrible. People must think that there's something really wrong with me. And that, I think, is a real problem for many people, especially for women, to just not feel ill, but look ill from the medicines that they're taking.
Well, I think there's another taboo of some sort that we talked about briefly last time. Men who have heart disease or have a heart attack, one of the common things that happen afterwards, especially if they have heart surgery, is sexual side effects, some type of dysfunction. Do you see that with the female patients that have heart disease who have been diagnosed with either a heart attack or had open heart surgery with a valve or bypass in your offices? Donna, have you seen that in rehab?
You know, I can't say that subject matter has come up with the females. I really don't know that I could speak to that. I could say that it perhaps, maybe it is a factor, but I really don't know the answer to that.
Because most of the male patients, I would say, not most, but I would say a significant amount, will complain of some type of dysfunction, either mentally or realistically, post-bypass or post-heart attack, because of what we give them, the medications like the beta blockers that might cause some types of issues. So the female patients, what I've seen is more of a fear factor of recurrent of a heart attack.
Right.
Maya, Karen, have you seen this at all in your office with patients ever mentioning this?
My husband is afraid to touch me. He's afraid he's going to hurt me. But I haven't seen the same lack of sexual libido or performance that I hear from my male patients.
Maya, anybody?
Similar.
Same.
Doesn't come up frequently.
Well, that's
they don't complain of it.
Well, that's something that, like I said, I sometimes think that is a diagnosable condition that should be reinforced, that this is normal behavior, to basically that medications can cause us. We can always titrate them if we had to, but the important thing is communication.
I appreciate that, because I think that that's something that we need to emphasize a little bit more with our female patients. Perhaps we haven't done a good job of that.
Well, and also because going now back another step, when a patient comes to see me, and a female patient especially says, I have belly pain, but I think it's just indigestion, let's all remember that females present differently than males with classic heart attack symptoms.
Absolutely.
We're always thinking about the elephant in the chest, the businessman playing golf with the pressure in the left arm and the jaw, where a woman might say, I have some back pain and indigestion, went to the ER and found to have, wow, I was having a STEMI or a big heart attack. Have you seen that, Karen? Maya?
Oh, yeah, absolutely.
Absolutely. I remember many times I'll talk to someone and I'll specifically ask, have you been having any shortness of breath with exertion? Can you do as much this year as you could last year? Because people don't think of shortness of breath or just fatigue with exertion as being a heart symptom, but it often in women is. But I had a woman in the office one day who was a tremendous minimizer. This lady never liked to upset anybody by having any sort of distress. And she was just nauseated. Just nauseated, that was all. She had no chest pain. She had no cough, she had no shortness of breath, she just was nauseated, and she ended up having a heart attack. So if something's just not right and it doesn't fit together and it doesn't make sense to you, come get it checked out.
Yeah, I would add to that because we have definitely seen some very interesting presentations for women, particularly when they're having a heart attack. But one of the messages I like to tell a lot of, well, anyone really, but particularly women, is that anything that's happening above the waist that seems out of place, not normal, you have to rule out that you might be having some form of a cardiac event. Because some of the presentations that we've seen, we could probably put in a book and no one would believe them that they're truly having a heart attack, because they're just so out of what you would normally think.
Out of the normal teaching, shall we say, which may not be the correct, because we we always base our studies on white males of a certain age,
Right.
and that's historically what most studies have been
Right.
based on. Maya, how about yourself? When you see females in the office, have they, or in the ER, when you've gone to see them to admissions, what have you seen differently? Is it mostly indigestion, back pain? What's been the strangest thing you've seen?
Difficult to say what was the strangest one because they often present atypically, especially if they have some other comorbidities like diabetes, which kind of masks chest pain, typical presentation. Difficult to diagnose problems in pregnant women because they have so many non-specific complaints, fatigue, shortness of breath, they don't exercise anymore because they're carrying baby. And it's sometimes difficult to sort things out. But if you spend time and if you talk with them, if you carefully assess their presentation, usually you have some clues, some reliable symptoms you can rely upon.
Now, Maya, let's go the other direction. So the patients who have been diagnosed with heart disease, Karen's seen them, I put stents into them, Donna's seen them in rehab, but they're still not doing well, and they need to have something even more, shall we say, invasive or potentially even transplant is an option. Why don't you comment a little bit about that, and women in the next stage, the assist therapy and possibly transplant?
Well, it would be a wonderful ultimate solution for the problem just to have an extra heart on the shelf to take off and to put into this chest, and she's like new. Sometimes it is an option, although with some limitations, which we hope to overcome as time goes and science progresses. But we have a program at USF of advanced therapies for heart failure and cardiomyopathies. We can evaluate in conjunction with Tampa General Hospital. We can evaluate patients for left ventricular assist device, which are basically mechanical pumps that replace your own heart and just circulate the blood for you because your heart is no longer capable of doing it, or heart transplant. And there is a very interesting moment in time right now because there are two wings arguing each other. What's going to be the leading direction in the future? Heart transplant or left ventricular assist device? With the heart transplant, naturally, you don't have enough of those because somebody healthy has to die to give this heart to somebody else who is healthy except for the heart, right? There has to be this match. And the number of donors is not increasing. It is quite flat over the last 20 or 30 years when the statistics was being run. And on the other hand, mechanical assist devices or mechanical pumps are getting more and more durable, reliable, miniaturized. It is not a huge thing that doesn't fit into a woman anymore, which is used to be. The first generation of the pumps was like this.
And to be honest, I remember working with them years ago, and they were huge, and they were sticking out of the patient, and they were meant for large males.
Only large males, even smaller males could not fit them. But now they came up with the really, really small device, and they're getting smaller and smaller. And it's amazing how much progress has been done over mere like 10, 15 years. It's really not even fast evolution, it's a revolution that is going on in the field. But so far we have second generation and experimentally third generation of mechanical heart pumps. I have to say that for now, still your own heart is better than either mechanical heart or another human's heart. So it only the treatment for people with really, really sick hearts. But it is here, and we are more than happy to evaluate anybody who thinks they may be ill enough to get this kind of therapy.
Well, I think this is great because the panel we have right now, we have pretty much all walks of the treatment paradigm for a patient that comes to the office. We have from the start point, we have from obviously the more interventional standpoint, the rehab and the cardiovascular service standpoint, and then the finality of potentially a LVAD or a transplant. I think it's important that women understand that options exist right now. And that's something that I don't think many women realize. They feel that they may be outside the realm of the current standards of therapy. It's not just for men, it's going to be geared towards everyone. And women in particular have to be more aware. So I think it's communication rather than just the therapy, because we have the therapies apparently. It's the communication with the female patients to understand that, listen, you have that heart just like he does, and you can be treated just like he is as well. So, ladies, I'm going to basically close up here. It was a great panel today. So let's start here, Donna, with some closing remarks.
Well, what I would like to leave the community with is that all women again, have that potential risk, and we need to know what our numbers are, know where we stand, what our risk factors are, and that the good news is that cardiovascular disease is largely preventable. And that's the part that we need to get involved in personally and be our own advocate with our physician.
Maya?
If they're not preventable and they still develop, we will be happy to treat them and help as much as we can.
Karen?
I'd like to reiterate that it is indeed a preventable situation, and come in, see your family doctor, find out what your personal risk factors are, and then take the steps with improving your diet, getting some exercise, taking care of yourself and your family, and do everything you can to keep your heart healthy.
Perfect. Ladies, thank you for being a great panel.
Thanks for being a great host.
Yes, indeed.
Thank you all to my guests for joining us today. This month is a great opportunity to recognize breast cancer and breast cancer survivors. But please, ladies, take time to listen to your heart. It just might be trying to tell you something. Remember, a positive mind is a positive body. On behalf of my guests and METV, thanks for watching. We'll see you next time on the Pulse of Manatee.